Welcome to Mayo Clinic Q&A. I'm Dr. Sanj Kakar. We continue our coverage on COVID-19. As the disease spreads across the United States, we are still learning new information about the disease. Back with us again via Skype is Mayo Clinic infectious disease and vaccine expert, Dr. Greg Poland. Dr. Poland, thanks again for joining us.
My pleasure.
How have you been, Dr. Poland? How's your weekend been?
There doesn't seem to be any distinction, probably for all of us as healthcare providers, between weekday, weekend, morning, noon, or night.
Yeah, exactly. I was going to say, especially with the weekend Sunday talk shows, obviously Dr. Fallujah had been on as well. How do you stay abreast of all of this information that's coming out?
Well, it's interesting just how fast it does move, and in some ways it's easy, some way harder for me because I'm also the editor of the journal Vaccine. So you feel kind of bombarded. Fortunately, and I'm very fortunate, I'm a speed reader, so I can take a lot in quickly and use a trusty notebook to jot down ideas or data that I want to remember. But it is a 12-hour-a-day job.
Yeah, no, absolutely. As we move from the weekend, what are the major headlines that you would like to share with us that you think our listeners should be privy to?
Yeah, I think a few things, and I'll start at the sort of world level and work to the U.S. As of this morning, there's 735,000 known cases. That, of course, is the tip of the iceberg, with almost 35,000 deaths now. Tony Fauci mentioned over the weekend that he estimates, and it's really the modeling estimating, that we may see somewhere between 100,000 to 200,000 deaths in the U.S. Right now, we have 143,000 known cases in the U.S. with 2,500 deaths. It's worth thinking about some of these things as this displays somewhat differential epidemiology in various places in the world. In Italy, for example, for reasons that one can speculate but not always clear, they've been much harder hit. In fact, 61 of the Italian physicians responding to this crisis have died, 40 of them in that Lombardy area. I think some good news is that the end of this week, we should hear one of the first drug trials of 3,000 COVID patients where they've looked at remdesivir, Kaletra, hydroxychloroquine, and interferon beta. We're also beginning to see data from Houston and China on plasma therapy. So that is good. The other good news is the FDA did give an emergency use authorization for an Abbott assay that gives results in about 5 to 15 minutes. Mm-hmm. And they think they can deploy about 50,000 of those tests a day. Maybe two other things that are new on the medical side would be that investigators at UCSF have identified 8 different strain types of this COVID-19. It mutates about 8 to 10 times slower than influenza, and thus far, none of the strain differences appear to have any different clinical manifestations. And I think the other thing for our cardiology colleagues is it's beginning to be better understood that there are cardiovascular implications for COVID-19 in terms of myocarditis, arrhythmias, and other manifestations of vascular inflammation.
Wow, that is scary information regarding that. We hear a lot about peaks, and for example, in New York, New Jersey, Connecticut, their peak may be different to elsewhere in the country. Can you explain to our listeners what does that mean, and why is it different there, say to elsewhere in the country?
Yeah. This really is a function of time, and what's happening is that I think, as expected, based on travel patterns, demography, et cetera, our larger cities are where not only are people concentrated, but where the risk is concentrated. Mm-hmm. And so you see these almost like epicenters of disease that people then leave from. For example, in New York, people have been fleeing there such that the governor of of Florida has put in place rules about isolation, and they're checking people's temperatures at the border.
Okay.
So trying to get a handle of this. And what will happen is that each of those sort of epicenters will then be the sources for people leaving and infecting other people all the way through, middle America.
So is this something related to contact tracing? We heard about that this weekend.
Yes, I think it's very definitely person-to-person spread. And what's been difficult about this compared to SARS is it's quite evident that people shed the virus asymptomatically, unlike with SARS. And so it's very, very difficult. And really the only practical thing you can do, and certainly you and I and other healthcare providers understand how difficult and disruptive this is, but social distancing is really the only thing that is going to dampen this down. And there is a really important and I think hard for people to understand is the lag period. What we're seeing today, which is still on the exponential uprise, what we see today is a reflection of transmission that took place 14 to as long as 28 days ago.
Okay.
So it gives you an understanding going forward that we're going to really have to see that curve bend down and wait another month before sort of sounding the all clear.
Well, so how are we doing in the United States about flattening that curve?
Yeah, in some cities, one gets the sense that it may be dropping a little bit, but, I'm really hesitant to make much of numbers over just a few days. I think it's pretty early yet to know.
Yeah, this is sobering information. You mentioned about the risk of, for example, myocarditis. Can you explain how the SARS-CoV virus makes people sick? How does it actually do that?
So, if we look at that cartoon of the virus behind you there, we see those little spike proteins, so-called S proteins. And you can think of that as a key. And the lock is a receptor called the ACE2 receptor that's displayed on the outside of human cells, which includes the heart, the bladder, of course, the lungs, and even the colon, the GI tract. And that virus attaches like a key into that lock, unlocks it, gets into the cell. And then what this virus does is it takes over our own cell's machinery and uses our own cellular machinery to make more of itself, more of the virus.
Okay.
And then literally bursts that cell open and the virus freed to go and infect the next cell next to it. And just to give you an order of magnitude, I was talking with one of our lab medicine colleagues, and he was talking about the RT-PCR assay we have, which has a lower limit of detection of about 5,000 copies. When they're testing patients, so imagine just taking a nasal swab or a throat swab, there are hundreds of millions of copies detectable from that swab. I mean, it gives you a sense of the enormity of the infection and the burden of that inflammation on the body.
Absolutely. And so you mentioned about the burden of disease. Initially, we were told that coronavirus had a preponderance for people who are older with medical comorbidities, but now we're seeing younger people are being affected. Do you know why that is?
Yeah, so we definitely see older people and younger people who have comorbidities having higher case fatality rates. What is unclear is why age alone seems to be such a strong driver. And what we don't have very granular data yet is it at the population that you're 60 or 70, or is it that, okay, you're 60 or 70, but you've got heart disease, hypertension, diabetes. So what about the very fit, sprint triathlon 70-year-old?
Sure.
They appear to be having illness, but are they having the same case fatality rate? In the younger people, we certainly do see serious illness, but much less in the way of fatality, fortunately.
Thank God. Thank goodness. Now, you mentioned about the virus mutating. If you've had coronavirus and you've been asymptomatic or you recover from it, what is the risk to you down the road? Do we know that information?
Yeah, it's a really insightful question and a key one, because of course we'd like to know that somebody's no longer at risk, and on the healthcare side, we'd like to know that that person could be deployed and be used on the front line, so to speak, without risk. The problem is we don't know that. We will soon know and be able to do serology where we can test for that antibody. Granted, we don't know the correlate of protection, so what level of antibody. There are also differences in inoculum size. So, for example, a layperson walking in the grocery store next to somebody that might be infected has a lower inhaled inoculum size than, say, an anesthesiologist who's trying to intubate, or a pulmonologist who's doing a bronchoscopy, where that load, were they not taking precautions, would be quite high. The other thing that we do have some data, this is fairly new data. If you look as long as 6 years out in patients who had SARS in 2003, they appeared to maintain high enough antibody levels.
Okay.
By 6 years, that dropped off. So that's one point of data. The other point of data is in the seasonal coronaviruses, that immunity appears to only last a few months to a year. So, here they are, they're all coronaviruses, yes. They're all beta coronaviruses acting differently in the immune system. So as I try to point out to people, one has to realize that with this particular strain, our expertise only extends 12 weeks.
Wow.
So a lot to learn.
Yeah, absolutely. You earlier mentioned about some data coming out about the trials, and you mentioned plasmapheresis. Can you just educate us a little bit about what plasmapheresis is?
Yeah, thank you for that question, because I think it's one of the more rapid things we could deploy. So the idea here is that you would take blood, you'd plasmapherese off plasma, which contains immunoglobulins, so it's polyclonal, but you're taking off antibodies or immunoglobulins from somebody who has recovered from the disease, and then transfusing that into somebody else. The issues with that are several-fold. One is you might get a dose, maybe 2 doses from a recovered patient that could be used in another person per time that you plasmapherese them. So it's not going to be a huge source.
Okay.
The other thing is it's being used under emergency use authorization. So generally in people late in the course of disease. Now there has been some data that got published Friday in JAMA, Friday night, as we were talking about earlier. and it seemed to show some potential benefit, but you really don't know until you do a clinical trial. I personally think it's going to have to be deployed earlier in the course of disease, but likely will have some efficacy at any point. And I think we're going to have to follow along to see how long is somebody protected. That's passive immunity that will wane with time.
Oh, I see. Okay. As a healthcare worker yourself and myself, and we've seen it now, more and more healthcare workers are obviously at the front line, and but they have lives to lead, they have families to lead, and they go home. How should they be protecting their families?
Yeah, I get a lot of those questions, and I, of course, have great empathy for them. I would say several things. The ideal thing, we're talking about frontline healthcare workers, the ideal thing is that you wear scrubs and a lab coat, and you put those on when you come into the facility, you take them off when you go out of the facility, and you don't wear those clothes home. Number 2, something I know some of my colleagues didn't think of. There's no reason to take your stethoscope home with you. Your stethoscope is something that you ought to be cleaning between patients anyway. We have the tradition of wearing a coat and tie, as you and I are right now. You don't want your tie trailing onto the patient and then going to the next patient. Not that I know that that's any kind of valid way of transmission, but We know that viruses and bacteria are harbored on our clothing. The other thing, and you cannot emphasize it enough, is high quality hand sanitizing. You really do not only have to use hand rub between patients, but you've got to wash your hands well before you go home. You're a surgeon, and surgeons and infection control people are the only people I've ever seen wash their hands properly. And when you think about it, we tend to concentrate on our palms and the lower third of the digits, but that's not what goes in your eyes, nose, and mouth. It's your fingertips.
Yeah.
And people ignore that. So that's really important to do.
Yeah, well, thank you for those tips, because obviously, we want to take care of our patients, but we also want to take care of our colleagues as well. And if we don't have healthy colleagues, we can't take care of patients. So thank you for those top tips.
I guess the other thing that goes without saying is, obviously, if you develop cough, fever, something like that, I probably would not go home. I'd find some alternative living situation if I knew I was infected before returning home.
Yeah, that's we thought about that. That's sometimes easier said than done, but you're absolutely right. So this is just Monday, and everything changes with time. What are you anticipating this week if you look in your crystal ball?
Yeah, well, interesting you say that. I've remarked to family and friends that I have renewed sympathy for the weatherman. But what I think we can accurately say is the following. We are not at the peak yet, so we're going to continue to see an increase in cases in our major cities, with spillover beginning into the Midwestern and Southwestern, Southeastern states, and they will then begin to be epicenters. I think we'll begin to see testing become more widely available. I think, as I mentioned, by the end of the week, we'll have a little more clear data if this study from France that's been coordinated out of France releases their data by Friday, as they say they will. We'll have a little more clarity on possible routes of treatment. I think the other thing is that I didn't mention this. One other hopeful piece of news, this won't happen this week, but by September, Johnson & Johnson's going to be starting a phase 1 trial of another COVID-19 vaccine, and I think we'll see others. So, in many ways, when you think about this compared to any other time in human history, it is remarkable. It's astounding how much has happened in 12 weeks. Do we all wish it could be yesterday? Of course, but this is unprecedented in every way. The U.S. I think really did take seriously preparation, and they're doing pretty well. I know at Mayo Clinic, while you always wish you had more in the way of resources, Mayo also took this seriously and has done a bang-up job in preparedness.
Yeah, absolutely. I think when you see adversity and then you see the human spirit come through in the innovation, not just at Mayo Clinic, but around the world, and people collectively coming together, I think that's a pause for hope that we'll get through this.
One other thing, if I can just mention a brief history, because it has, after 9/11, there were a lot of surveys saying that in a bio event, there was a lot of concern that healthcare workers might not come to work. And I think clearly you and I have seen just the opposite. I mean, the magnanimous sacrifice on the part of our brothers and sisters who are every day much closer to it than I am. I get a teaching role, but those that are intubating somebody at the bedside, I mean, unbelievable the hours they're working and the risks that they're taking on behalf of patients. And I at one level, I want to say, bravo, we have lived, and we've all, basically taken the pledge, simple 7 words, the needs of the patient come first. And they're really living that. And, historically, I did a grand rounds on this. In 1918, Mayo was one of the first medical centers to buy, it was a hotel, but set up a hospital outside of St. Mary's, which they called a contagion hospital. And the nurses, they were all sisters at that time. One after another, it is recorded in our archives that they would catch the pandemic influenza and die. and the next nurse and the next doctor would pick up the stethoscope and go in there and take care of patients.
Well,
I mean, it's amazing story.
Yeah, well said, Dr. Poland, and thank you for sharing that with us. Our thanks to Mayo Clinic infectious disease and vaccine expert, Dr. Greg Poland. As always, great information to help our listeners better understand the COVID-19 pandemic. Thanks, Dr. Poland, and stay well.
Thank you. You too.